Hey, this is Dr. Craig Chappell with another weekly peek. Thanks for joining us again. Today I'm going to, I don't know if this will show it or not, but to the mountain way up there with snow on it, that's where I'm headed today. It's called Corral Peak. In order to get here, I came up the left hand of Hobble Creek Canyon in Springville, Utah. I've never actually been to the top of this one before. I've always wanted to. In order to get there, there's a bit of a parking spot here. The road gets really rough, and so I'm going to take a four-wheeler up there, at least to the trailhead, and then hike the rest. For today's weekly peek, I'm going to talk about SI joint dysfunction, SI joint pain, and a little bit about low back pain, and a lot of misunderstanding that goes along with that. In my practice, I take care of a lot of SI joint dysfunction, SI joint pain, SI joint related pain, and SI joint laxity. And so I'll kind of walk through that process, kind of what it is, what you can do with it, and other possibilities, and sometimes what it's misdiagnosed as. So come and join me, and hopefully I'll have something to share with you. Tell you a little bit about myself. I always, as I went to medical school, loved manual medicine, physical medicine. I love working with healthy people. But in order to get to do fellowships after medical school, you generally have to participate in a residency to understand chronic disease processes that would allow you to treat people effectively and hopefully not miss important things, important red flags. And so I did a residency in family medicine, and it was awesome. I learned a lot, but it was never my hopes or aspirations to continue that path. But there was a fellowship called neuromusculoskeletal medicine and osteopathic manual therapies. This fellowship, we learn or hone in our skills to participate in manual therapies, exercise prescription, and anatomy. And so I really have a passion for anatomy, so that's something I always wanted to do. So I was fortunate enough to get into a program with a doctor named Dr. Anthony Chila, one of the authors of the Foundations for Osteopathic Manual Medicine, and just really well known and well respected throughout the world. And I got to spend a year with him, and he was older at that time, and he is still around, but it was a great year actually. His name is Dr. Anthony Chila, and I remember my first time working with him. The words that kept coming out of his mouth were, "Dr. Chappell, slow down." I'm like, what? Let's just get a steroid, inject a steroid in that shoulder, cover up the pain, hit it with a shotgun without actually knowing what's going on. The patient won't leave. They'll be happy for a while at least, and maybe time will heal it. And he reminded me time and time again, why don't we find out what's going on with the patient? Why don't we find out what's going on in their body that led to a rotator cuff repair that we can correct, either manually with exercise, physical therapy, or lifestyle modification. And so I really appreciated that insight, as in the real world and the real doctoring world, it's how fast can we get a patient out of our office versus why don't we sit down, listen, and then maybe do a great physical exam and decide what we can do or have to offer for these patients. So I appreciated that advice. About the same time, my dad, who is a PhD in psychology and sociology, I asked him about this listening, and he said that generally most doctors make their decision on what's going on with the individual within the first minute of stepping into the room. But he said, however, if you listen long enough, the patient will tell you what's going on. In fact, they'll usually tell you their diagnosis as well if you listen. And so I've really taken that into account and put that in my quiver. And I think I've become pretty good at it. In the practice that I've set up, I schedule that time necessary. So that was useful. But after that, that year of fellowship, I didn't feel like I still had a handle on anatomy, physiology, diagnosis, and kind of the more advanced processes of the musculoskeletal system. So I did a fellowship in sports medicine, spent another year doing that. And during that time, I was introduced to musculoskeletal ultrasound. It was just starting its way onto the scene, and it was awesome. I loved it, fell in love with it very quickly. And we had an ultrasound in our fellowship, but nobody really knew how to use it. So I spent that year traveling all over, learning from the best who didn't charge me. They let me come to their offices, went to courses. It was awesome. They taught me all the things that took them years to learn in, just a year. And so I was very appreciative. I was very blessed and fortunate to have those opportunities. During those years, I've often heard the phrase, I stand on the shoulder of giants, and it's true. I didn't get here by myself. I was able to absorb information from countless experts and be able to implement that. So I don't know if that gives me the right to give you medical advice, but I sure hope it helps you achieve your goals or whatever it is you want to do. But that's a little bit about me and my story and how I've got where I am and been able to create a work environment in which I do have time to spend with patients. I generally don't have to see any more than 8 to 12 patients a day, and it's fantastic. So don't know if that helps you, but as we start talking about SI joint dysfunction, maybe it will. And if nothing else, you get to see some pretty awesome scenery. I've consulted the map, and I am not on Corral Mountain. Corral Mountain is the one just back there in the cloud, and it's actually 200 feet higher than where I'm standing, so it's actually not that much, which is a shame, because I could do that if it wasn't like 3 miles away. And the one kind of directly behind me in the center of the screen is Provo Peak, which is over 11,000 feet, I believe is what the map said. So about 800 feet above where I'm standing. So missed it. So man plans or man dreams. Maybe I should have planned a little bit better. Next time, maybe I will, maybe I won't. I still ended up somewhere awesome. All right, everybody. So I've tried to get into a kind of a shady spot where I can give an anatomy lesson on SI joint and SI joint dysfunction. So I'll do my best to do that. But what you see right now highlighted in blue is called the sacrum, where we're looking at basically the back of a person. Now the blue is the ilium. So that forms the sacroiliac joint. So the joint between the sacrum and the ilium form the SI joint or sacroiliac joint. If we get rid of the ilium, so we'll kind of hide that and we'll turn this on edge, you can see that the articular surface of that joint, I'll make it unblue again, basically right here, you can see that circle, is not very smooth. If we turn it back around, you'll see that it looks a little different than most joints. Hence the SI joint is not like an elbow joint or knee joint in which it hinges or moves a lot. It actually appears that if it's designed not to move that well. Overlying the joint are what we call the posterior sacroiliac ligaments, and which blend into what's called the sacrotuberous ligament. And that basically locks the SI joint together. So what does this mean as far as anatomy is concerned? Although it's a joint, similar to other joints in the fact that it does have a synovial portion to it, which means it has joint fluid and everything else in it, it's not necessarily like other joints in the fact that these ligaments allow transition of forces through the joint, but not necessarily motion through the joint. So when you bend over, you're actually hinging at your hip joint, which is over here, and not your SI joint, which is here. So that allows for transition of forces when you're walking, running, and those types of things. All right, we may come back to anatomy in a minute. Let's talk about how the SI joint behaves. So when you're walking, running, those types of things, you land on the ground, forces go up through your leg, through your pelvis, in your back, in your arms, wherever else it's spread. So as we come across low back pain, which is oftentimes SI joint pain, it's difficult to discriminate. But generally in most cases, people with SI joint dysfunction, SI joint pain, will point to the SI joint. So when asking to describe their pain, they'll actually reach back with their thumb or finger and point directly at the SI joint. As far as skin landmarks, you've seen those two dimples on basically above people's butt crack. Right above that, there's two dimples. If you can't see your own, look at somebody else's, you'll see those two dimples. That basically represents the top of the sacrum, which is the beginning of the SI joint. So when people point back there to describe their pain, they're below the lumbar spine. The name for that sign is called the Fortin finger sign because it's pretty specific for SI joint pain. So what causes SI joint pain? Is it a dislocation or a subluxation of the SI joint? Does it require stretching to get better? Well, it turns out the SI joint is not supposed to move that much. And so people that have problems with SI joint dysfunction are unfortunately generally female. So it's almost 9-to-1 female versus a male problem. There's a couple reasons for this, a couple of which are estrogen progesterone cycles. It's a fact that females during the time of menses or on their period are more likely, especially the younger females that are playing sports, are more likely to injure their ACL, which is a ligament, during their period than at other times during their cycle because of the fluctuations in estrogen and progesterone, which do have a tendency to affect connective tissue, so ligaments. We also know that during pregnancy or in the beginning of pregnancy, there is a hormone released by the corpus luteum called relaxin. So when you are sustaining a pregnancy, the relaxin, which is released during the first trimester and the third trimester pretty potently, causes relaxation of ligaments. Then after delivery of a baby, the oxytocin and prolactin, the two hormones that promote breastfeeding and breast milk production, also have a tendency to relax ligaments. So hence, this is generally a female problem more often than a male problem, although we see it, like I said, 1 in 10 times will be a male in the office. And so the problem or the pain generator from this is actually the ligaments. And they're called the posterior sacroiliac ligaments. So the joint in and of itself is very rarely the pain generator. The pain generator is generally the ligaments. So if addressing the pain or doing a diagnostic injection of your pain generator, you may consider injecting the ligaments, either with lidocaine or marcaine or even a steroid if you choose to go that route. But it's much more effective to inject the ligaments than it would be to inject the joint itself. It seems more rewarding, and the pain can be reduced more greatly with injection of the ligaments, which is generally done with ultrasound guidance or some sort of guidance technique, so you actually ensure that you're actually injecting the ligament. So that's a good way to confirm the pain generator. So if you're able to inject it with the anesthetic, your pain goes away. More than likely, a ligamentous pain and SI joint dysfunction. So what do you do with it? That's a hard question, because the problem is laxity of ligaments, which doesn't respond well to stretching. So I see a lot of information, if you have SI joint dysfunction, go ahead and stretch it like crazy. The problem is stretching. And so what about manipulation? Well, if it's a forceful manipulation and you're actually stretching the ligaments during that manipulation, may not be the best thing either. In my clinic, we do a lot of exercise prescriptions, so specifically to very specific muscles. I'm going to pause right here, go back to the anatomy, and we'll talk about some of the important muscles in SI joint dysfunction, because it's very targeted. In this case, it will be gluteus medius. So we're back. I'm doing the best I can with the technology that I have. Like I said, my battery died on my GoPro, so this is a little bit difficult to do. But as technology inept, this is as good as I'm going to do. So we're once again looking at the posterior pelvis. I'm going to point to that muscle. It should turn blue. There it goes. So that's the gluteus medius. It inserts on the ridge of the iliac crest. Hence, I'll make that actually disappear for you, and we'll be able to see the iliac crest a little bit better. We'll get rid of this one too. This is part of the erector spinae musculature, which inserts there as well. And I'll get rid of a couple more so you can recognize the sacrum again. All right, so there's the sacrum. So the sacrum there, so the ilium is here, sacrum down here, those are the ligaments, and then I'll make the sacrum blue. There you go. So you can see that if I hide the gluteus maximus, which is a big time stabilizer of the SI joint, if I hide that, the bigger stabilizer is the gluteus medius. So gluteus medius is pretty important based on its location. So based on its location, gluteus medius is a external rotator of the hip. So if you think about what gluteus medius does, think about an ice skating muscle or roller skating or rollerblading muscle. It's the out and back motion of your leg that fires the gluteus medius. The gluteus medius is the primary stabilizer of the SI joint. So if the SI joint becomes destabilized, secondary to hormones, secondary to trauma, secondary to overuse, the next best stabilizer you have beyond the ligaments are the muscles. And in this case, gluteus medius. So it's the out and back action. So better than stretching would be start an exercise program. If you think about throwing a baseball, that's what we're going for. We're looking for not necessarily a great deal of strength, but coordination of movement. So what exercises promote gluteus medius health? Well, a great exercise is walking uphill. Well, people say, well, what about just walking? Walking doesn't take much effort, and especially from the glutes. So if you're walking on a daily basis, that's a great cardiovascular exercise, but it doesn't take a lot of muscle activation or muscle activity to sustain that activity. So walking uphill would be fantastic. Walking sideways would be fantastic. Any resistance bands or activities that's out and back would be fantastic. So kind of at and back angle from your body, which will be demonstrated at the end of this video. So those types of exercises are actually fantastic for gluteus medius strengthening and SI joint stability. But remember, the muscles are the secondary stabilizer to the SI joint, whereas the ligaments are the primary stabilizer to the SI joint. So what works on ligaments? Well, you can't rehab a ligament very well. There are some physical therapists that are qualified to do dry needling, which can stimulate a wound repair response with the acupuncture needle that can be helpful for mild SI joint dysfunction or mild SI joint pain. As far as moderate to severe SI joint pain, being as strong as possible is the best thing you can do to assist in stabilizing the SI joint. But once it gets out of hand, you then have to think about the possibility of regenerative injections, which work fantastic for SI joint dysfunction and SI joint laxity. And that's what we do primarily at my office. So there'll be a link to regenerative injections if you want to learn more about that. But the intent of a regenerative injection is to cause very specific inflammation and the wound repair process to the posterior sacroiliac ligaments and the ligaments that surround the pelvis, which will stabilize the pelvis and decrease pain and disallow that motion. So there's kind of a notion that the SI joint dislocates and or goes out of place. Secondary to that irregularity of the joint, it doesn't really dislocate or go out of place. It can shift on occasion, and it will require some manipulation on occasion to get it back, which can be helpful at eliminating pain immediately, but doesn't do anything to take the injury out of the ligament. So you may have to consider, like I said, regenerative, or the best thing being as strong as possible in your glutes. So that's what I would recommend. The other thing you want to think about as far as adjustments are concerned, if adjustments are forceful and they take a lot of force through your SI joint to get it where you want to be, or to make it feel better, because sometimes just the shift of a joint does make it feel better, you might want to lay off on that a little bit, because if you're stretching ligaments and the ligaments are already a little bit lax, maybe not such a good idea to continue to shift that around. As far as possibilities for auto correction or corrections that you could perform at home, anyway, just to recap some advice or some thoughts on SI joint pain, low back pain, that type of thing. A couple things. If you point to your low back just below your belt or around your belt line to describe your pain, it very well could be SI joint or coming from your SI joint. That's rule number one. As far as things, other possibilities, there could definitely be other possibilities, but generally down that low, it's going to be associated with SI joint. Other possibilities or red flags, things you need to watch for that may not be SI joint related, would be pain that wakes you up at night, pain that wakes you up in the night in the presence of other arthritic conditions such as psoriasis or psoriatic arthritis, and pain that gets a lot better with activity. That generally is typical of another type of arthritic process that you'll want to see your rheumatologist for, called ankylosing spondylitis. That is not a SI joint laxity. It can be associated with it, but generally treated a whole different way. As far as first steps to treat SI joint laxity or SI joint pain, exercise is going to be the best bet. Being as strong as you can for as long as you can is going to be extremely helpful. One thought about pregnancy. So a lot of people during pregnancy, a lot of females during pregnancy get SI joint related pain. And the unfortunate thing about it, if you get it during one pregnancy, the likelihood of getting it during the next pregnancy is pretty high. But not only high, it usually starts earlier in the next one. So going into those pregnancies, being as strong in the gluteal musculature as possible is extremely helpful. As far as flexibility is concerned, really the only two stretches that you'd need to worry about are hip flexor and hamstring. Those are the two big muscle groups that insert onto the ilium, so that one bone associated with SI joint dysfunction. So lengthening those theoretically could be helpful, but that's a muscle tendon group, not a ligament group. And as far as hamstring stretches go, I like hamstring stretches to be done while lying on your back, so you don't involve your low back and SI joint. It kind of locks them out of the picture. Another way to treat it on your own is mindful walking. So walking with a short stride, really focusing on what your SI joint feels like and trying to shift it back into place, or back to a less painful position to take stress off those ligaments. One more thought about pregnancy is, if you are in pain during pregnancy, several studies have shown that osteopathic manipulation in conjunction with exercise has been fantastic at alleviating some of that back pain or that low back pain or the SI joint dysfunction in pregnancy, as it's expected as your ligaments loosen during that time period. If you have any other questions about this, please let us know, but hopefully this has been helpful. As far as other treatment options, once you move past the conservative options such as exercise or osteopathic manipulation, you're getting into more injection therapies. Diagnostically, it's super helpful to do a lidocaine injection. If your pain goes away and you inject those ligaments, your pain probably is SI joint laxity or SI joint related. More specifically, the connective tissue around the SI joint. If that works, you're moving on to a different form of treatment, generally starting with regenerative injections, which work fantastic in and around the SI joint and the posterior sacroiliac ligaments, and done with guidance, like usually with ultrasound. You can really do a good job at hitting those ligaments and adding integrity to them, strengthening them, and it works very, very well. When those things start not to work, the conservative options, then you're looking at the possibilities of radiofrequency ablation, where you go in and ablate or burn or cut the nerves that go to the SI joint, which can be helpful. But if you're young and you're doing that, that's not really a long-term solution, because those generally last anywhere from a year to 18 months. But if you're 30 years old, are you gonna do that every year and a half for the rest of your life? Probably not. And then for really, really loose SI joints that are unlivable and unmanageable with everything we've talked about, then surgery may be necessary, but the surgeries are extremely permanent and they're a big deal. So they generally put 3 triangular rods through your ilium into your sacrum, which fixes or fuses your sacrum together and generally eliminates a lot of the pain. However, in order to get there, you have to go through your glutes and a couple of possible arteries and nerves to get to where you want, and the outcomes are okay. You're generally in a wheelchair for about 6 weeks following the procedure. There are things in the works coming down the line for a little less invasive SI joint fixation technique, but still it's kind of a big deal. So that's reserved for those things that have failed every other conservative option, because you're not going backwards after that procedure. Hopefully, like I said, this answers some of your questions. Sorry my batteries died, but I've enjoyed this opportunity, and hopefully we'll see you next week on the Weekly Peak.